Karuz has already shared his screen. Thank you so much, Karuz, for joining this early morning. Thank you.
Good
You can go
morning,
ahead.
Jay, and good morning, everyone. Thank you for the kind invitation. It's a pleasure to share with you an interesting surgical presentation. So this patient had a history of retinal detachment surgery, and subsequent to surgery, about 2 days later, and this was done elsewhere, 2 days later developed severe pain and ended up in the emergency room. At the time, the pressure was somewhere around 50 and was diagnosed with suprachoroidal hemorrhage. And at the time also, this patient was on Coumadin, and the INR was checked, and the INR was 10. So, and that, so he was hospitalized to bring the INR down, and then subsequently was referred for management. We waited somewhere around 2 weeks for the lead to blood, that suprachoroidal blood to liquefy, and I thought I'd just go over the surgical procedure with you, and then we can have a discussion. So here, as you can see, so what I did was putting the trocar, the retina pretty much is touching the lens. So I just go straight into the suprachoroidal space with the valve trocar through pars plana. This is a phakic patient, so about 4 millimeters posteriorly. You can see the blood is already coming out. Since the retina was so bulously, basically separated with the suprachoroidal blood, I knew that the trocar would probably be in the suprachoroidal space. I used the vent that allows me to drain that blood in a controlled fashion. As you can see, still, I'm now injecting BSS into the anterior chamber to pressurize the eye, and you can see now the blood is just coming out. And obviously, you can also do a anterior chamber maintainer. This patient was phakic, the pupil was really dilated, so I was concerned that it may touch the anterior chamber maintainer may touch the lens, especially since I was manipulating. One key point is depression. You have to really do a lot of strong depression to push the blood to come out from the suprachoroidal space. And I did this maneuver pretty much 4 times all around, so pretty much putting it in every quadrant, again, in the pars plana, and then by applying pressure, draining this suprachoroidal hemorrhage. Subsequently, went into the eye, had also vitreous hemorrhage, removed the hemorrhage. The retina was already attached, so just didn't need to do an air fluid exchange. And again, just to play it safe, I put another gas bubble in also to make sure it doesn't bleed. And here you can see the post-operative presentation, and when the gas bubble has gone. During the surgery, pretty much drained somewhere around 80% of suprachoroidal hemorrhage. Many times you cannot drain everything. Some residual blood stays back. And the one thing you can see, actually, the retina looks good, but the challenge is, as if you look at the optic nerve, it's cupped. It's somewhere around 0.9 cupped, and this is probably due to increased intraocular pressure post suprachoroidal hemorrhage. And this is, I think, the biggest challenge, because when you get suprachoroidal hemorrhage, there is not much you can do till you wait for that blood to drain. And during that time, someone's depression with all the maximum medication may not be lowered adequately. One interesting learning point here is that many times we pay a lot of attention when our patients are on Coumadin to what is preoperative INR, and make sure that it's somebody, like many of us, I'm sure, feel comfortable if it's around 2 or below 2.5 that we still operate. But the key is also to pay attention to postoperative INR and just make sure that it does not go out of whack and that the INR still is controlled. Again, thank you for giving me the opportunity, and happy to discuss. Again, one key point was here that I just did not go to do any posterior drainage. I just went into the pars plana. Once it was drained, you have to remove the trocar and reinsert it again into the vitreous cavity to do your pars plana vitrectomy. For immediate drainage, I just drained it through the pars plana.
Excellent case, Karuz. Amazing video, as usual. So I was just wondering that, do you put the patient on oral steroids in those 2 weeks? Did you put the patient on oral steroids?
Yes, for pain, for pain, not for anything else. If there is severe pain, and again, if you have a choroidal hemorrhage postoperatively that is not as severe, but if the patient, usually that extension of suprachoroidal space is painful, and you just give them some tapering dose of steroid to for a few days, for 4 or 5 days, just for pain purposes, for comfort.
Okay, and I think you brought out something really important, the INR, and because as a retinal surgeon, we all get into the pre-op area, and the anesthetic nurse is standing with that, oh, your patient has INR of 4, so you are like in a situation what to do next. But do you have any certain protocol with you or at your institute where you want to follow up this INR of less than 2.5 for a few weeks, then you jump in? Because something like this is pretty unexpected, having a 10 in the post-op.
Yeah, again, this was not my patient, so I don't know what the situation was. Generally, from my perspective, as if we can stop, if an elective case, if I can stop the Coumadin, we stop the Coumadin. If they say the patient needs to be on it, just on the day of the surgery, prior to surgery, we check the INR, make sure it's below 2 or 2.5. I did have a patient, and these are again rare, with a retinal detachment that need to operate it that day. And because it was a macula detachment, and the patient was on Coumadin, and I think at that case we gave fresh frozen plasma, and they gave 2 units before surgery, and then that happens. I think you need to give it like 1 or 2 hours before surgery, somewhere around that. They recheck the INR, you do the surgery, and then you're back to, because the fresh frozen plasma I think has a limited half-time, and then they go back to the Coumadin, and then you are done. That's for those rare cases, but in general we just do it below 2 or 2.5.
And what about, sorry, go ahead, Alex.
Oh, I was just going to ask a question. Chris, great presentation. For these patients, do you modify anything anesthesia-wise? Do you avoid retrobulbar and do subtenons, or do you prefer general? Do you modify anything when they're on blood thinners? Maybe not in this particular case when it's better control, but a patient where you find out that INR is higher than what you would want it to be.
Good morning, Alexander. Yeah, great question. Yeah, actually, generally, I'm doing most of my cases on their laryngeal mask anesthesia, under LMA. So from that perspective, it does not change what I do, because I don't do a block, but I definitely would not do a block. And most likely also be more cautious if I'm needing to put a screw buckle, that I talk with them, and then I think twice, am I going to put the buckle here or not, if the patient is INR with Coumadin with an INR of 2.5. But I definitely, and one additional point that you bring up is I also discuss with them that you are on Coumadin, there is always risk of bleeding, is low, so we're going to proceed, but that risk is there. So I mention it again to them before surgery and on the day of the surgery, so they know that risk is there. Again, it's rare, but if you got the bleeding, so that you're aware of it. But great question.
Good. Any other comments from
Jay, can I?
Please.
Yeah, you see a fantastic video and fantastic result also. Only thing is that I normally put, you see, needle infusion first, and then a non-valve cannula rather than a valve cannula. Because if I heard correctly, what Korus mentioned was a valve cannula. I would have preferred a non-valve cannula in this. What is your comment, Korus?
For sure. You can do it anyway. The reason I use the valve cannula, for one reason, is we don't have any more non-valve trocars available. We only use valve. But and the second thing is, what I liked about this was it was more controlled, because the lumen, again, is smaller. So you don't suddenly have, again, because I was so anterior, I just want to make sure I do not get the retinal incarceration. So I was just keep monitoring when I was depressing to make sure that, and then at some point towards the end, I would pull the trocar out. So it's like halfway in, just to make sure I do not end up getting an incarceration. You can definitely do it anyway. The goal is to get a drainage through that space. So absolutely right.
Yeah.
Just a quick question. Sorry, Gopal, go ahead.
No, please.
Yeah, so I just had a quick question that Korus brought out something very important, that you can only drain the peripheral choroid. Sometimes you can have the suprachoroidal hemorrhage trapped posteriorly. How passionate you are, or how aggressive you get to remove that posteriorly trapped suprachoroidal hemorrhage?
So great, again, another great question. This is not necessarily only anterior that we drain, because the suprachoroidal space is connected. So I go with the depressor very posteriorly and massage that blood to come anteriorly. you know, and that allows you to drain most of the blood. I think the problem is that no matter how you drain, part of that suprachoroidal blood is always clotted and you cannot remove it. I'm not too aggressive about that. I think that usually goes away on its own, and there's not much you can do about it. If it's clotted, it's clotted. You cannot always drain the whole thing. But the goal is, you know, to decompress the eye, decrease the pressure, and let the body do the rest on its own.
Perfect. Thank you.
Two
Gopal?
quick points. One is that usually whenever we put in silicone oil, especially in the presence of retinal detachment, you will finally end up in underfill and probably will require to do it again. Number two, in a presence of subretinal hemorrhage with an anticoagulant on, would you stop the anticoagulant and then operate, or we would operate with the anticoagulant on so that the blood is still liquid when we are operating?
That's a great question. Again, it has to do with the general health of that patient. If you basically you want to do it on the minimal amount of anticoagulant. If you can decrease it, you decrease. Basically, that becomes a discussion with the cardiologist or whoever put it on to see what you can do. But you want, basically at the end, you want to do with least anticoagulation as possible. But again, this is a discussion with the medical team. You make an excellent point regarding the fill. If obviously, I usually then put a gas bubble in these cases, because as you know, the fill of the oil is extremely important. If you get an underfill, the oil doesn't do anything. So you rather have 70% gas bubble with the patient position than, for example, a 70% oil bubble, because the 70% oil bubble does not do anything for you. Great point.
All right. I think we